So yeah, Doctor, thank you again for taking the time today and being with us. We really appreciate your presence. With that said, let's just jump straight into the book, as I'm sure the audience is very thrilled to hear about reaching through resistance. It's in the title. I imagine that the main book is structured around the resistance that is common to patients and clients when they are approached, let's say, by the therapist to try to reach out to them to help them in the process of therapy, but you encounter many forms of resistance and degrees of resistance in clients. So why don't you give us a little bit like the background about the title and well, yeah, the main topic of the book.
Yeah, so after a lot of thinking about it, we selected this title because the main function of this treatment is to help people overcome their obstacles to being present with another person in a self-caring way. So the automatic patterns that come up of behavior and avoidance that don't allow close contacts with other people in a healthy way. And all of that is based on being hurt by other close relationships in the past. So automatically when a person comes into therapy, automatically old behaviors come in, old habits, old avoidant patterns, in what we call defenses, come up, and they make it difficult for the therapist to engage them and it's difficult for them to heal these past problems. So the concept of reaching through the resistance is that in this treatment model, the therapist is very active in recognizing and handling the resistance and helping the person see the way they avoid a healthy attachment process and avoid their own emotions that come up. So it's quite active. It's not sort of more waiting until the defense goes away, because oftentimes in longer therapies, the defense just doesn't go away. It needs some active engagement and therapeutic processes that have been developed by native Iranian Dr. Habib Davalou, who originated this approach in the 1960s and onward, working to make treatment more efficient, more active. And that's what the basis of this work. After 20 years of my training exposure to him and 25 years of clinical experience, I put it all together in this book.
Fantastic. Thank you for that introduction, Doctor. Then I suppose my next question would be that, well, you mentioned the theoretical background of the book. I myself, for example, come from a cognitive behavior background. And what would you foresee as someone from a different school of psychotherapy coming into this book and coming into ISTTP? How would they approach the book, especially the two basic structures of it? Because I think there's two parts of one part theoretical and the second part more practical. So if you could give us your thoughts on that a little bit.
So different therapeutic languages like cognitive behavioral therapy, they have their own like languages to describe phenomena that are often similar and sometimes significantly different. The term unconscious versus implicit, exposure versus experiencing of feelings, there's different languages and there's certain overlaps. A colleague, Nate Toma, and I, who's got a strong background in CBT, we wrote an article to try to cross-reference between cognitive behavioral therapy and ISTDP treatment. The first part of the book, as you say, it gives us sort of basic theoretical elements that helps orient a person to the clinical material that comes in the later chapters. So that helps ease people into it. And people doing cognitive behavioral therapy, you recognize that there's resistance to some things that happen, and there's things that are obstacles in the treatment. And my general experience is that they're relieved when they can see some other approaches that are logical, even in a cognitive behavioral model, to try to handle those resistances.
Indeed, it's oftentimes like I feel like we haven't developed the necessary language and therefore the conceptualization of resistance as some other approaches. So getting some more let's say help is tremendous. Then on that though, then Doctor, can we delve a little bit more into details of the book and also the concept of resistance? So what is resistance in a clinical therapeutic setting, and how, in what forms or varieties does it showcase itself?
Yeah, so we talk about resistance as defenses, automatic old behaviors to avoid emotions and engagement. Those defenses that operate in the room with the therapist, those are resistances. So those defenses, there's different categories and types, but the main big blocks of resistance, one is isolation of affect, where the person can intellectualize about their emotions but not feel anything. They can talk about it but not be in contact with the feelings. So that includes intellectualization and rumination and the various ways to detach from the feelings, even though they can be aware of it. The next is repression, where the emotions just disappear into the body, into depression, into muscle weakness, into the smooth muscle of the body, includes the stomach and the blood vessels, making migraines, stomach problems, bladder problems. So that's the second level. The third is primitive defenses, projection, where an emotion inside the patient is projected out onto the other person or onto nothing. It's projected into thin air, and they hear a voice, a hostile voice coming, and sort of splitting, so where the things are split into all good, all bad, and projective identification, where a set of features in the person is projected out. So that category is primitive defenses. There's another whole chunk of defenses that we talk about is resistance of the guilt. So it's sort of a self-destructive drive where the person is continually putting anger inward in different ways, in different forms, sometimes very overt and direct. So getting sort of a self-punish system going on. So those are like the main blocks of what we call major resistance, which defends against intense rage and guilt. There's another little category, another significant category of defenses are called tactical defenses, which are minor little things like the person saying maybe a little bit, being vague. They sort of like can be little tactics that really get the therapist to go away from some focus. But sometimes you can just ignore them and they go away. So they could be just very small defenses, or they can be stuck into the bigger defenses, into these other ones. So more like part of the major resistance. So we talk about a spectrum of two spectra of patients. One spectrum of psychoneurotic disorders goes from low to moderate to high resistance. Mm-hmm. And these groups of patients all have some ability to isolate affect and intellectualize and defend in different ways. The low resistant patient, though, they don't have much defenses at all, only a few tactics. The high resistant, they have a hard block of defenses, very much rigidly held, very detached, and a whole lot of other kind of character defenses, which is another kind of group, controlling the defiance, compliance, passivity, helplessness is a big held character armor. So that's that spectrum. The second spectrum is the ones with patients with fragile character structure who, when they get anxious at a certain level, they use primitive defenses and they get confused, losing their vision, getting blurring vision, hearing problems, mental confusion, or even going unconscious sometimes. So that group is fragile group. So obviously we're going to treat these groups different. And if you want me, I can say something about that.
Absolutely. In fact, well, first, thank you for the brief description of the spectrum, and precisely the difference of approach to the treatment of these, let's say, the fragile repression patients versus those who are overly defended is also one of the audience questions that we received that they would like to know, especially from ISTTP perspective.
Yeah, so there's the low and moderate resisting patients who I mentioned. they are relatively open for the treatment. You focus with them on the feelings that rise up when they're talking about things in the present. The feelings come up through, and then it's connected to the past trauma or the past losses. The higher resistant group, if you try to reach to the feelings, they put major walls and barriers that they can't even see. So you have a major job then to help them recognize these habits and patterns and behaviors coming up, to turn them against those, and to turn them, to see the destructive effect of those behaviors and to turn them against those. And when you do that, it causes a lot of feelings to break through with you, including a deep appreciation for your effort to help them stop hurting themselves, but also irritation with you. And so those mixed feelings with us is a sort of the key to unlocking the unconscious, where the person past mixed feelings come up in the moment with us.
Mm-hmm.
So with more resistant, we have a bigger job to help to turn against the defenses. That has some piece of like cost benefit analysis in the cognitive behavioral language about the destructive nature of this behavior, to recognize it, to be aware of it, and to turn against it. So that's the more high resistant. Now, the patient with a lot of repression or a lot of this fragility, you can't go directly to the feelings, or they get sick or confused or scared and paranoid even. So you have to go in a more gradual way. And there's different sort of forms of capacity building, so they can learn to reflect on their emotions, reflect on their body responses. And what that does is it makes the anxiety more tolerable. It makes the ability to isolate affect comes in, where they can see things and tolerate better. Then they start to be able to experience these complex feelings and open the unconscious. So it's 2 steps there in the case of a lot of repression and fragile. So it's a very different looking treatment. One you could say is like a lot more like supportive looking,
Yes.
and reflection, building reflective capacity. The other is more defense handling. And the low resistant patient, they're already open. So it's really not that much work. No, I don't know how it is where, depending on where your clinical work is, you might see some low resistant patients. I can tell you in the hospital where I work, we see fragile, 90% are fragile or repression. And then the other ones are highly resistant mostly. We see almost no low resistant and moderate resistant in a hospital here. So private practice, some people will be low resistant, moderate, and high resistant. So some are more have better anxiety tolerance, and then you'll see some fragile in there. In the private office, in the public setting, if you're working in a community hospital, a community clinic, you're going to see a lot of fragile, a lot of repression.
Wow, that's very fascinating, Doctor. Why now my curiosity is piqued about this. Like, why do you think this discrepancy between the private clinical setting and a public sector is this like there's a reason behind that, do you think?
Yeah, I think that people who are more kind of resistant and solid, they tend to be able to earn more money, and they tend to be able to pay for private therapy. And the people who have had like more neglect and more trauma, they tend to have more fragility. They often have a lower income, and they have trouble getting organized to get treatment even. So they end up in the public system or hospital, or in the emergency department with physical symptoms and fainting attacks and things like that.
I see.
So that's the other place is medical offices. Medical offices are full of patients with these problems. It's affecting the muscles, affecting the stomach, affecting blood vessels, getting confusion. Like the neurology office are full of patients who you can use this treatment for.
I see. Very fascinating. Actually, then occurred to me that the type of the patient itself that directs the kind of the framework of treatment that they would seek out. Then on that point, Doctor, if we go a little bit back and broad picture of the book, especially the background, obviously the book is based on many thousands of, as you also mentioned in the introduction, thousands of your own personal case studies. We would like to know what were, let's say, the highlight of of your experience, or maybe some of the more challenging or difficult things that gave you inspiration for a particular chapter, or any personal story that stands out in the process of writing?
So the yeah, I mean, there were certain specific cases that I built the chapters around. I changed the information and such. So,
That's really
I blended material. But when I started to do this work, I was working with resistant patients only at first. And I wasn't working with the other repression or fragile patients at first. I didn't feel comfortable to do that in my first few years. And then as I started to work with the fragile group, over time, I saw that, this is really a neglected group of patients who get too many medications. They get pushed around the medical system. They get rejected out of the mental health systems. They land in jail. Many of them end up dead, I think, because of the projection. Projection causes violence. A person projects the hostility, then they're fighting people on the street, or they're yelling at each other in restaurants, things like this. And then people can get badly injured or die from this. So this is a group that's not well served in the public system. So that's something I've been putting a lot of energy into teaching about. And probably I'm working on another book on fragility, but you can see like a third of the book is on fragility. This is the hardest to treat group, so I put a lot of time into the last chapters of the book. The other thing with the fragile group is they bring a lot of feelings up in us therapists. So the therapist can feel infuriated, rage coming up in themselves. They can feel horrible, painful feelings. It can be heavy for the therapist. They also tell very difficult stories of terrible abuse. And that's also very difficult on the therapist until they get used to all these things. So that's, a group that I think, the other part of it is this group, it costs a lot in the public system. They're on long disabilities that the government has to pay for, or companies. They're on medications forever. They're in hospital for extended periods. They're in a psychiatric system. Very expensive. And so the system should put resources to treat that group, but they have to have some treatment that's going to be able to be effective. So this is a way to compress treatment for this group, to compress psychodynamic therapy, which is effective for this group, to try to compress it down. And so I think that's one of the big contributions, I think, that this book comes. The other is depression and people who don't respond to antidepressants or respond to first-line therapies. And this book, is kind of a manual for the treatment-resistant depression too. So you can say the 3/4 of people that don't respond to antidepressants, which is a very high rate, we shouldn't accept we're done with them, that we've tried all the pills and now we stop. Or even trying a few therapies. If they're that stuck, we need advanced treatment models for that group. And this is what this model is about people who fail other treatments. Mm-hmm. And that's, again, the main contribution that Dr. Davenlou brought in building this approach was to expand it to people who couldn't respond to other therapies, who were very stuck in their psychotherapies, in and out of hospital in some cases. So I think that's the main contribution to this book, most important part.
I see. Excellent. That was a very clear description, Doctor. Well, that's let's say the perspective from, like, say, a very, very well-established therapist. If you would give any tips or any comments about up-and-coming therapists, especially using this book, or wanting to approach a resistance situation from an ISTTP framework, what would you say? Because I'm sure there's a lot of in our audience that are,
Yeah. One thing to say is that it's often a challenge for most people. It's a significant challenge to learn to understand and work with these populations I'm talking about, especially the more resistant, fragile, and repression. And it's So that takes training, supervision, self-reflection. It takes time. It's not something you can kind of go to a workshop and learn. It's even unsafe to try to do that, because if you think you're going to go spend even some weeks or whatever do a workshop, and then you're going to work with these severely ill patients, I think it's a bad idea. So training, there's different kind of core training programs that are 3 years in duration, and they have several days per year, and they have courses attached to them, and there's expectations to read and look at your videos. It's all video-based training, by the way. The teaching's from video, the self-review is off video, all the supervision's from video. So it's as hard. It can be harder depending on the trauma load in the therapist. So if the therapist has a big trauma load, it's harder to absorb the concepts and be able to work with the person and not be affected by their own trauma. So sometimes it takes longer to train because of that, and sometimes people get their own treatment sessions. That should be done independently of the supervisor. It should not be the supervisor doing all these things. It should be, have a colleague or someone over there that you can get treatment a block or more. So that's a complement to the training, formal training. Reading, I've seen people who reread this book, and it comes out, it's all broken up. The book is all broken. They're reading it over and I did the same with Dr. Deho's book. I would wore them out from reading them and reading them. So it's just to repeat to get it into ourselves, so it becomes automatic. The other thing is we need to be patient with ourselves learning this, because it's hard and it takes a lot of demand from us. So we need to be taking care of ourselves when we're doing that. And we need supervisors that also will take care of ourselves when we're doing that. So that it's not harmful for the person trying to learn it, right? Yeah. But I think it protects from burnout. I don't know how the problem is of burnout over there, but burnout is a significant problem for clinicians and the mental health system and the medical system.
Absolutely.
And I think it's partly because they're faced with people's trauma, and their own trauma gets stuck in there. And then they're all worrying about their patients. They can't get their patient out of their head, for example, or they get angry at the patient, or they throw out the patient. And then they get a complaint against their medical license. I mean, this kind of stuff is very heavy on a clinician. So it's knowledge of this helps that. So teaching the physicians, we teach surgeons, we teach the physicians, we teach the psychologists. They have at least some information about this. And it's good to know quite a bit about it, so we can know ourselves as well as a clinician.
Absolutely, wholeheartedly agree, doctor. Thank you. Yeah, I think we are almost out of time, sadly. As much as I enjoyed the conversation, I think we've also covered quite a bit.
Okay.
Before we wrap things up, of course, I would like to ask you, you mentioned your book that you're writing on fragile patients. We are curious to know what is next for you, what kind of projects you're busy with right now, books or research or
Yeah, I mean, we have a lot of research going on. One is there's a new meta-analysis of all of the ISTDP studies coming out. There are a couple of reviews of the cost effectiveness and of the approach for somatic symptoms and of the approach with the resistant complicated patients. Those are all in the works, and they'll be out in the next year. These are articles. As far as the book I'm thinking about what I want to put on it. It really will be building out the last chapter of the book, which is there, but I mean, it'll be built out with more details on interventions that I've really been working on in the last 5 years and teaching. It's sort of more details on how to assess and work with fragility at different levels. But I'm trying to think how I can keep it not being too big of a book because it's a lot of content tends to go in there. So,
well, a fuller book is not necessarily a bad thing. So looking forward to it. Fantastic. And For those who would like to follow your work or get to know more, what is the best way to reach out or to
Oh,
your
there's a website, www.alanabbas.com, or reachingthroughresistance.com is the other one. It's the same website.
yeah.
So if you just put reachingthroughresistance.com, it has articles. There's many articles linked on there. There's media, like interviews like this, podcasts. There's so there's all kinds of things, and there's some training opportunities that are somewhat there as well.
Fantastic. Thank you, Doctor. Thank you again for taking the time today and being with us. I
Okay.
wish you best of luck with the future projects, and I hope our paths cross again. Who knows, maybe the next book or maybe in person, it's a small world, so who knows?
Okay, that's great. All right, thanks for having me.
Thanks for being with us. Have a pleasant day, Doctor.